So, as far as today's presentations, what we're going to try and present to you is a basic knowledge of what nets are and how they work. We'd like you to know what questions to ask your doctor, because you can and should be part of the decision-making process when it comes to your treatment. And the basic thing is that there is something that can be done. In most cases, there are things that can be done. There are treatment options for the disease. So, the physicians, the speakers today, have tried to do their presentations in layman's language, but don't let that fool you. These are high-level talks. These are tremendous talks that give a lot of information. So if you don't have your pen ready, make sure you get it ready. So our first presenter was a member of an exclusive research program at Rensselaer Institute. He was awarded the Mosby Award for Outstanding Research in Virology. He was awarded fellowships at North Shore University for medical oncology. He's held teaching positions at NYU and Cornell. Currently a senior attending physician on staff at both North Shore and at LIJ. I didn't know you were this old to be able to do all this stuff. He's participated in over 20 research projects in the field of medical oncology as a principal investigator, and published several papers in nationally recognized journals. So with that all said, please welcome Dr. Hal Gerstein.
Thank you, Bob. First, before I get started, I want to thank Bob, Mary Ann, and Tricia for their yeoman's work in this organization. It's really amazing what they've been able to accomplish in really such a short period of time. My relationship with them predates Tricia, actually, when I met Mary Ann when she was still pregnant, dealing with a non-malignant blood problem that we were able to solve without any issues. And then Mary Ann came back to me when after she was diagnosed with the neuroendocrine tumor, looking for somebody who could help her locally. At the time, there really wasn't anybody out on Long Island that had any kind of expertise with this condition, and she asked me to look into this, and I have, and it's become one of my niches, and I'm very proud to be associated with the organization. I am a solo private practitioner. I'm privately owned by myself, and don't have any obligations to any other entity, be it a hospital, a corporation, or anything else. So my primary interest is strictly with my patients. So we're going to talk today about prioritizing treatment options for patients with neuroendocrine tumors. And to do that, we need to know a little bit about what neuroendocrine tumors are. So we're going to briefly go into a little bit of a history. The term carcinoid cancer was coined at the turn of the last century, the early 1900s, when a pathologist looked at tumor specimens and said they looked like carcinoma, but they didn't behave like carcinoma, and hence he coined the term carcinoid, or carcinoma-like. Turned out to be pretty much a misnomer until a few decades later, when they found that these so-called carcinoid tumors not only arose from the neuroendocrine cells and traveled to different parts of the body, therefore we can see carcinoid or neuroendocrine tumors arise from many different parts of the body, but they had specific properties. Some of them could produce peptides, which could be vasoactive and result in a slew of symptoms that some of our patients demonstrate. So because this group of malignancies, these neuroendocrine tumors, are so diverse, many different challenges can present to the clinician or to the doctor, and that is some of them may produce symptoms associated with different peptides produced by the tumors. And these peptides run the gamut of vasoactive polypeptides, GI polypeptides, and insulin-like polypeptides that can wreak havoc with our metabolism. Neuroendocrine tumors can arise from different areas of the body. As I said, we tend to first classify them into foregut, midgut, and hindgut. The most common vastly being the midgut, appendiceal, small bowel, and ascending colon carcinoids. We also see a fair amount of foregut carcinoids, bronchial carcinoids, or pulmonary carcinoids, occasionally arising from the stomach as well, and rectal carcinoids, hindgut carcinoids, are also can be seen. Pancreatic neuroendocrine tumors are basically an entity in and of themselves, PNETs. PNETs occur from the islet cells of the pancreas. This is different than the run-of-the-mill adenocarcinoma that you see all the TV ads for the Lustgarten Foundation, etc. That is a more common pancreatic carcinoma or an adenocarcinoma. They tend to be much more virulent, much more malignant, and carry a much worse prognosis. PNETs arise from the islet cells of the pancreas. These are hormone-producing cells. We used to call them islet cell tumors when I was in school way back when. We now call them pancreatic neuroendocrine tumors. They generally are metabolically active. They can be insulinomas, producing insulin, therefore lowering one's blood sugar. They can be glucagonomas, producing glucagon, raising one's blood sugar. They can be VIPomas, producing vasoactive intestinal peptides, which can cause massive diarrhea. So these can be clinically very significant for us. As I said, it's a whole different category of PNETs. Some of us know it as Steve Jobs' disease. That's what he had. What's going on with neuroendocrine tumors? Why are we having these conferences and why are we getting so much play now? That's because the incidence is rising dramatically. And compared to, the neuroendocrine tumors are rising dramatically compared to other cancers. Okay, and this is a 5-fold increase in neuroendocrine tumors in general over the past 30 years. Compared to other malignancies, okay, all other cancers, the incidence is pretty much flat. Neuroendocrine tumors are rising. Okay. What's that from? I can't tell you. Maybe that's from our increased awareness of the diagnosis. We're just being more aware of it and we're making the diagnosis, so the statistics are being skewed that way. Or maybe, in fact, it is a true rising incidence. I really can't tell you at this point. Okay. But I can tell you that the incidence of neuroendocrine tumors, the rising incidence, is not just confined to the United States. It's happening all over the world. And what about stage? Okay, the incidence of neuroendocrine tumors being diagnosed by stage, okay, is increasing out of proportion to localized tumors. What does that mean? That means that groups like NCAN are doing a terrific job of educating the public, both patients and physicians, in looking for these tumors and diagnosing it at an earlier stage. So important in prognosis and treatment of our patients. So that's really a good thing. Gastrointestinal pancreatic neuroendocrine tumors are clearly the most prevalent. digestive system, much higher incidence than anything else. Okay, and the lung tumors are second. As far as gastrointestinal cancers in general, compare a neuroendocrine tumor to a colon cancer. Compare it to a pancreatic cancer, okay? Neuroendocrine tumors are the second most prevalent type. Colorectal cancers, by far number one, very common gastrointestinal malignancy. But neuroendocrine tumors are the second most. They're more prevalent in stomach cancer, more prevalent in esophageal cancer, than liver cancer, and even more prevalent than pancreatic cancer. We really need to get the word out more about this disease. Natural history of neuroendocrine tumors. I'm going through this quickly because we're going to get to some really interesting stuff, so I want to get through this. Natural history of a neuroendocrine tumor is such that, for a long time, the disease goes undiagnosed. There's vague abdominal symptoms, and only until there is widespread metastatic disease do we then get some of the other symptoms. So it's very important that when a patient still has these vague abdominal symptoms, much like what Bob mentioned Mary Ann was going through early in her disease, that this be diagnosed, because you can catch it earlier if you're attuned to it. Because many of the physicians are not attuned to it, NETs were often diagnosed late in the disease. So we don't like that. We want to change that paradigm. It's a progressive disease. Of course, it is still a cancer. It's a slow-growing cancer in general, but it is still a cancer, and given time, it will cause death. We try to classify neuroendocrine tumors by that. It's been attempted to classify neuroendocrine tumors by various methods over the years. The WHO, the World Health Organization classification, is a good starting point for us. We try to classify NETs as a good prognosis versus a poor prognosis, and we'll always have those intermediate liars in between. But a well-differentiated tumor with a low malignancy rate, a Ki-67, which is a marker that pathologists will look at and should be reported on all pathology slides, will be low, okay, and tumor size is usually low. Those are usually good prognostic signs. Poor prognostic sign is on histology, or when the pathologist looks at the tumor, it's a poorly differentiated. Okay? Ki-67 is high and could be any size. You could have a small tumor with a high Ki-67 and looks bad and could still have a poor prognosis. So size is not always important. Why is tumor grade important? Because patients with well-differentiated tumors do better. Patients with poorly differentiated tumors do worse. Stage, why is that important? Patients with localized disease or early stage do better. Patients with metastatic disease or higher stage do worse. So again, localized disease or regional neuroendocrine tumors are favorable, but a significant portion are metastatic at diagnosis and have a poorer prognosis. Neuroendocrine tumors are malignancies that arise in the cells from the neurocrest and can migrate to different parts of the body. The incidence has been increasing, and survival is very dependent on tumor grade and tumor stage. I'll briefly talk about diagnosis and evaluation because our other speakers are going to go into this in more detail. The constellation of symptoms can make the diagnosis very difficult. As Bob mentioned, okay, the symptoms of early stage disease can be confused with many different entities. Food allergies, menopause, irritable bowel, peptic ulcer, neurosis. So it takes a good clinician to try to weed this out from their patient. And it also takes a good patient history. So when the doctors ask the patients for specific information, we need to get that from our patients. We can't read our patients' minds. Again, early symptoms are non-specific and generalized. We'll skip this slide. Because these symptoms are non-specific, it often leads to a delayed diagnosis. And sometimes that diagnosis can be delayed up to 5 to 9 years. And that gives the tumor, unfortunately, enough time to metastasize. And again, many NETs are asymptomatic until they're metastatic. The index of suspicion has to be raised when we're dealing with neuroendocrine tumors or patients that come in with these vague abdominal symptoms, so we can make the diagnosis earlier. We can use patient's history, physical exam, certain biochemical markers, chromogranin, 5-HIAA, pancreatic polypeptide, etc. So we have to use this systematic approach in order to properly make the diagnosis. Once we have a suspicion, we can then go on to imaging, which will be talked again later in detail in today's lectures. But we'll talk about Artria scan, CAT scans, MRIs, gallium scans, and endoscopic ultrasound. Now let's get to the meat of the matter. Over the years, we have shifted from concentrating on symptom control for patients with neuroendocrine tumors to a more aggressive tumor control. For many, many years, the only one of the only weapons in our armamentarium had been symptom control. But over the last few years, we've made great strides in identifying some newer ways to attack tumor control. And that's really what we want to do ultimately for this disease. Basics of therapy for neuroendocrine tumors starts with surgery. Surgery can be primary or curative if the tumor is still localized and you have a skilled surgeon who's able to remove all, or if not all, the majority of the disease. Surgery is also important as a palliative procedure in order to debulk the tumor and leave the remaining medical practitioners less tumor to deal with, which will make my job easier. We also have directed therapy, and what I call directed therapy is directed therapy to the liver, such as ablative therapy, and PRRT, which will be touched upon later in one of today's talks. PRRT is protein receptor radionucleotide therapy, which would be an up-and-coming treatment. So let's come back initially and talk about supportive care or symptom control. We're going to talk about somatostatin analogs, and then we're going to talk a little bit about anti-proliferative therapy. Okay, we already talked about surgery as primary, palliative therapy, directed therapy, as I mentioned, hepatic artery infusion, radiofrequency ablation, radioisotope embolization. We'll talk about that later. Okay, one of my favorite slides. This slide's going to pop up at least 2 more times in various forms during the talk this morning. And we need to understand that the somatostatin receptor on the neuroendocrine tumor cell, okay, is activated and signals the production of some of the peptides, and that can result in the symptoms. So we need to find something to inhibit that somatostatin receptor. And there are 5 distinct somatostatin receptors, and more than 80% of neuroendocrine tumors express these somatostatin receptors, which makes it a good target for us to direct our therapy to. Okay. The somatostatin analog that we've been using over the years is octreotide. The long-acting one is sandostatin LAR. and that sits on the receptors, blocks it, and inhibits the secretion of the vasoactive polypeptides. Okay, the results with this drug is it causes a significant decrease in the number of stools and flushing incidents, a decrease in the 5-HIAA levels and the serotonin level, and it can actually also improve survival in patients with carcinoid crisis. We also use it prophylactically for patients that are undergoing surgical procedures in order to prevent carcinoid crisis. Okay. Side effects of this treatment include abdominal discomfort, some bloating, hyperglycemia, which is high blood sugar, gallstones, and hypothyroidism. And these are some of the things that I, as a clinician, will monitor in our patients getting somatostatin analogs. The newest analog that was recently released by the FDA is lanreotide or somatulin, the long-acting preparation, and they're for supportive of symptom control. The results are comparable. Okay, so a lot of times I'm asked, what can I eat, what can I not eat? So let's go through this quickly. Dietary recommendations that I give for my patients with neuroendocrine tumors. This slide's not in your booklet. It was added on, but basically avoid spicy foods and alcohol and make wiser decisions while eating, and that's going to improve your symptoms of carcinoid syndrome. And here are some of the choices to make instead of, okay? And just, you can look at that quickly, and if you need that handout, you can call my office or get hold of Irene Karp, who's my counselor. Irene, raise your hand, and she'll have that list for you as well. Okay, so somatostatin receptors highly expressed by NETs, as I said, over 80%, and that gives you the rationale for the use of somatostatin analogs. Okay. It can target multiple somatostatin receptors and can have direct and indirect anti-tumor effects as well. Okay. So not only will it affect the tumor, the symptoms produced by the peptides produced by the tumor, but will also affect the growth of the tumor. And in a study published 2009 called the PROMID study, okay, that showed that